The authors have no financial interests. Our world is facing a cataract crisis. Ensuring optimal surgical outcomes when patient volume is high remains a persistent challenge in a variety of healthcare settings. In 2015, Hostrup et al. Found that audits tracking surgical outcomes are not enforced currently in most hospitals, making quality assurance yet another obstacle. According to reports worldwide, there are a multitude of clinical information systems, but very few surgical outcome monitoring systems. The Aravind Eye Care system currently does more than 3 lakh cataract surgeries per year. In this high-volume scenario, manual data collection can be time-consuming, inefficient, and inaccurate. In 2013, we pioneered the Cataract Surgery Outcome Monitoring System, CAT-QA, to monitor our own performance and to produce highly accurate data about how our patients fared after surgery. CAT-QA allows surgeons to measure themselves. With just a few clicks, they can view a summary of their own operative outcomes, as well as changes over time. They can even compare their individual data with their colleagues' performance. CAT-QA especially helps trainees assess their status and improve their learning curve by understanding their individual performance. Chiefs and administrators can compare parameters with other hospitals in the database. This type of benchmarking is essential to understanding an institution's strengths and weaknesses and ensuring quality. Let's see how CAT-QA works. Here is the opening screen where credentials are entered. Features of the system include summary data, master's data, and benchmarking data. There are a number of factors that contribute to the uniqueness of CAT-QA. It is one of few such registries in the world for cataract surgery. The feature of automatic report generation saves time in searching for results. With one click, a user can track the outcome of specific groups of patients, benchmark surgical outcomes with surgeons in all available cataract indicators, compare one specific surgeon's data with surgeons in different hospitals of similar size, compare the hospital's overall performance with other hospitals in the CAT-QA system in all available cataract indicators, access a comparative summary data report which shows different types of cataract surgeries performed, different types of anesthesia used for patients and any associated complications, and data regarding intra-op complications, post-op complications, resurgeries, early and late post-op residual refractive error, and endophthalmitis incidence. Additionally, CAT-QA can show a graph for each surgeon trending 2 or more cataract indices selected, and compare these indices graphically with average and highest performing surgeons. A monthly report of all cataract indicators is routinely sent to each surgeon through an email delivery system. What is the impact of this monitoring system? Let's visualize this situation in the surgical flow based on CAT-QA generated data. 87.9% of the population has less than 1 diopter post-op spherical equivalent refractive error on average in all of our hospitals. To increase this further, we changed our biometry method from the applanation method to the immersion method in non-paying patients, SICS category. This resulted in change to an average of 93.26% within 2 years. Anesthesia-related complications are few in number when compared to the number of cataract surgeries we operate on. In order to reduce them from few to nil, we changed from peribulbar or retrobulbar anesthesia to subtenons anesthesia in 2016. Now the incidence is almost nil. Astigmatism should be properly dealt with to get best postoperative uncorrected visual acuity. Other than using a toric IOL, we made a decision to mark surgical incisions in the steep axis preoperatively on the IOL master sheet. When compared to 2017, data of 2018 showed a 5% increase in patients attaining a vision of 6/9 or better. Reducing the trainee complications is one area that Arvind is concerned with. 2016 CAT-QA gave us percentage of complications happening during surgical training through all our hospitals. We came up with the SAFE approach. It's a novel, cost-effective, yet simple device for ophthalmic surgical wet lab training. In 2017, there is a 20% reduction in complications seen. Endophthalmitis is always a nightmare for every surgeon and institution, and a feared complication of ocular procedures. Haripriya et al. Reported that with the usage of intracameral moxifloxacin at the end of surgery, the incidence of endophthalmitis has been reduced from 0.07% to 0.02%. This landmark paper has changed practice patterns not only at our institution, but across the world, and it is the direct result of having access to this wealth of data through CAT-QA. Evidence-based changes in patient care made our patients more satisfied. Till today, CAT-QA holds almost 1.7 million patients' surgical data. What's on the horizon for this kind of big data? In the era of artificial intelligence and machine learning, big data can lead to big change. For example, artificial intelligence can now diagnose diabetic retinopathy and predict cardiovascular risk factors, all from a simple fundus photo. Perhaps big data from our CAT-QA, used with deep learning algorithms, can one day predict surgical outcomes and improve ophthalmic care. If today we are experiencing this big change, we can be sure that bigger changes will be coming down the road.